patient, gingival recession are not isolated. And this happens more frequently in those situations in which patients have undergone to orthodontic therapy, and so multiple teeth has exposure of the buccal surface and multiple gingival recession forms. In terms of surgical procedure, we can consider a multiple gingival recession when at least 3 teeth, one close to each other, has gingival recession. Because if you have only 2 teeth with gingival recession, namely the canine and the first premolar, the lateral and the canine, and the central and the other teeth are completely healthy, we still have to use vertical releasing incision to separate the area with gingival recession from the area of the adjacent teeth that are completely healthy. But from the situation in which we have at least 3 teeth with gingival recession, or even better if you have 4, or even better if you have 5 teeth, or even better if you have 6 teeth with gingival recession, we can use a different approach of the coronally advanced flap, which is an envelope type of flap with no vertical releasing incision. The reason why I said you this is because when you use an envelope type of flap, obviously, since it's envelope, and since you don't have a vertical releasing incision, you have to extend your envelope flap to 1 tooth more with respect to the teeth with gingival recession to make your flap passive enough to be coronally advanced. And so if you have very small flap, you are obviously need to extend 1 tooth, and 1 tooth mesial and 1 tooth distal, your envelope flap. So you are going to destabilize or to treat teeth that are completely healthy. And so in order to make this flap passive enough to be coronally advanced, the risk is to put the keratinized tissue of the adjacent teeth that are completely healthy above the enamel and to lose this keratinized tissue. So the reason is, why do you have to include healthy teeth in your flap if they are really healthy? You can interrupt your flap with 1 or 2 vertical releasing incision once the adjacent teeth are completely healthy. Why? Since we increase the number of the teeth included when you have a greater number of teeth with gingival recession, you can also reach the possibility to make your flap free from muscles enough without increasing too much the extension to the flap of the adjacent teeth. Namely, is it enough, for example, to open the surgical papilla between the diseased tooth and the adjacent healthy tooth to make the flap passive enough to be coronally advanced and not to place too much keratinized tissue of the healthy tooth above the enamel. And as much as you increase the number of the teeth included in the flap design, the easier is to make the flap free from muscles without the need of extend too much your flap to healthy adjacent teeth. So that's why this technique is specifically indicated for treatment of multiple type of gingival recession. And the best situation you can find is when you have gingival recession from 1 to 5. Also, the mesial root can be included in the molar. And so you don't have to extend more than the teeth with gingival recession because the flap is big enough to give you the opportunity to make it free from muscles, to make it coronally advanced in a very passive way without including any other teeth that is healthy in the flap design. When you are treating gingival recession in the area included between the central incisors to the first molar, you are using the so-called lateral approach of the multiple type of coronally advanced flap. And in this lateral approach, you are treating all gingival recession from 1 to 6. And in this approach, you have to consider the midline passing through the mid-surface of the buccal surface of the canine as the rotation axis around which the surgical papilla has a different type of movement during the coronal advancement of the flap. In other terms, when you make a flap with vertical releasing incision, the flap goes down straight forward. When you don't make vertical releasing incision and the flap is an envelope type, you have two periphericus area, that is the area of the central incisors and that is the area of the first molar, that influence a rotation movement of each surgical papilla that you elevate inside the flap towards the periphery of the flap. And this rotation movement happens around an axis, which is that one passing through the midline of the canine. So all the papillas, you're going to elevate mesial to this midline, rotated mesial. All the papilla you are elevating distal to the midline, rotated distal. And so this is why the surgical papillae will be designed placing the tip of them in a specific situation, so to predict the rotation movement together with the coronal advancement of this surgical papilla, so that each surgical papilla will be placed above the anatomic desepitalized papilla at the end of the coronal advancement of the flap and not above the avascular root surface. So in order to understand how to make this flap design, you always have to start at the level of the canine. And at the level of the canine, you have to measure the gingival recession. In this case, you don't have to add 1 more millimeter for a reason that this amount, once the papilla rotates toward the periphery, you need more soft tissue to cover the gingival recession than once you coronally advance the flap with straight vertical releasing incision, because in this case you have very wide trapezoidal type surgical papillae, while in this case you have a triangular type of surgical papillae, and so you have to make them perfectly coincide with the tip of the anatomic desepitalized papillae, and so you don't have any excess of soft tissue that guarantee you success in the case of even small mistake. So my suggestion, and this is what you have to do, is to measure the depth of the gingival recession, not 1 millimeter more, but only gingival recession, and then the same distance you have to measure not straight but along the distal and the mesial papilla of the canine. So you measure gingival recession 4 millimeters, and you measure with a probe 4 millimeters starting from the tip of the mesial and distal papilla along the mesial and distal papilla of the canine, so to predetermine 2 points along these papillas where you can hand your submarginal incision coming from the most apical extension of the soft tissue margin of the 2 adjacent gingival recession. It is very important that you start from the most apical extension of the soft tissue margin of the adjacent gingival recession, and you get to these points that were predetermined at the distance from the tip of the papilla equal to reception depth, and not to do the contrary. Because if you start here and you go towards the canine, if you make a small mistake, you will get to the canine surface and nothing happens. While if you do the contrary, namely if you start here and you go apical, if you make a small mistake and you go further apical with respect to the end point, the risk is to cut the keratinized tissue, and this is a very big mistake. So in order to remember how to perform this incision, you have to remember that all incision must be made convergent. Convergent towards the canine means you start apically and go towards the canine. You start apically until you go towards the canine. Then you have to measure the gingival recession of the 4. This dimension has to be measured starting from the tip of the papilla distal to the 4, and here it gets the submarginal incision starting from the most apical extension of the soft tissue margin of the 5. When you make this submarginal incision, you have to consider to make a continuous line, ideal continuous line that continues the soft tissue margin of the teeth with gingival recession in this submarginal incision. Every single submarginal incision is the continuation of this soft tissue margin, because the soft tissue margin, you will never make an incision there, but it will be elevated full thickness with the periosteum elevator. And so once the flap will be elevated, you should not see any neck, any change in the shape between the soft tissue margin and the submarginal incision. So the submarginal incision is the really made by continuing with no interruption, with no neck, the soft tissue margin at the buccal surface of the tooth with the gingival recession that is continuing along the submarginal incision until you get to the adjacent tooth. Now you measure the gingival recession of the 5. The same distance is measured starting from the tip of the papilla distal to the 5. Adheres, you trace the submarginal incision starting from the soft tissue margin of the first molar. Now what you have to do is to measure the gingival recession of the lateral. The same distance is measured starting from the papilla mesial to the lateral. Adhere always with a submarginal incision directed towards the midline passing through the canine. You start from the most apical extension of the central incisors and you go towards the midline passing through the canine with no interruption, with no alteration of the ideal line that is the continuation of the soft tissue margin to the submarginal incision. This incision line, together with all intracircular incision, design 1, 2, 3, 4, 5 surgical triangular shape papillae. This is triangular shape papilla. That's why yesterday we tried in the exercise to get to be able to preserve the tip of this triangular shape surgical papilla, because if you make a mistake during trapezoidal split thickness papilla elevation, it doesn't change too much. You have a good blood supply, surgical anatomic papilla. While if you make a small mistake in elevating the tip of this triangular shape surgical papilla, this does not coincide anymore with the tip of the disepithelialized anatomic papilla, and this is a mistake that is repeated for every single surgical papilla, which is included in the flap design. So nothing will be done as it should be done if you make a small mistake, even in the tip of one surgical papilla. So you have to be very, very careful when you make a split thickness elevation of this surgical papilla to keep the tip of this surgical papilla very, very healthy, with the epithelium and connective tissue thickness included, because if it's too thin, it remains only epithelium, and this is going to go to necrosis during the healing process. While after elevating split thickness of all surgical papilla up to an imaginary line which is connecting the soft tissue margin of the two adjacent gingival recession, exactly the same thing we did for the trapezoidal type of flap, the buccal keratinized tissue must be elevated full thickness by inserting the periosteum elevator directly inside the sulcus area. You have to look for the bone, and then you have to go further apical for about 2-3 millimeters in order to give some periosteum to the alveolar mucosa covering the root and the bone, before reaching the so-called lining mucosa of the lip, where you have to make the two different incisions, as we said yesterday, one deep to detach the submucosal tissue from the periosteum, and one very superficial to detach the submucosal tissue from the inner aspect of the alveolar mucosa and make your flap free. What is more difficult in this case is that this split thickness incision that you have to make apical, you cannot look at inside and see exactly what you are doing with your knife. But since you know what you have to do, namely during the deep incision apical, you have to remain parallel to the bone first, minimally apical, 2 or 3 millimeters, no more, deep incision until you see that the submucosal tissue with the alveolar mucosa is detaching from the periosteum. Then the movement of your blade is completely changed, and you have to become superficial by using your blade in the inner aspect of your alveolar mucosa, and you can check the movement of your blade by transparency through the very thin lining mucosa as I showed you before, so you know that you are really getting rid of all submucosal tissue from the inner aspect of the alveolar mucosa. There is also another aspect that you have to consider here, which is different from the flap with vertical releasing incision, and that is the area of the interincisor papilla. In the area of the interincisor papilla, you don't have to open the papilla. You don't have to make any split thickness incision at the level of the papilla because this is not necessary. And if you leave the anatomic interincisor papilla completely healthy, this is a very good anchorage for your corneal advanced flap at the time of the suture. So what you have to do here at the level of the interincisor papilla is the so-called hemitunnelization of the interincisor papilla. Namely, you have to get rid of muscles and submucosal tissue from your flap, getting below the soft tissue, interincisor soft tissue, but with no need to elevate the surgical papilla. And the same has to be done at the level of the molar. You have to overcome split thickness, the area of the furcation area, and make the flap free even more distal, even more apical, in order to make the rotation of the papilla, make the papilla between the 5 and 6 rotate and cover the anatomic disepitalized papilla. The remaining corneal portion of the anatomic papilla must be disepitalized to create connective tissue bed to which your surgical papilla will be placed and anchored by means of sling suture at the time of the at the end of the surgery. But now we see the step-by-step movie. Again, even if you are treating multiple types of gingival recession, if there is some abrasion defect that has to be restored with a composite restoration, this has obviously been done before starting the surgery, and this is something that has to be done in multiple teeth. This has to be done before the surgery in multiple teeth. So, for example, in this case, there was a canine with very sharp interruption of the enamel. As we said yesterday, during the biological and diagnostic phase, you cannot cover this line, but you have to make your composite restoration in order to create a very, very regular, convex surface of the clinical crown in order to place your corneal advanced flap in the right position. And the same if you have sharp interruption due to abrasion defect at the level of the premolar. You have to do the same thing. You have to continue your cemento-enamel junction in a more apical direction in order to avoid any risk of collapse of the soft tissue and to leave this area uncovered. This is true for every single tooth that has to be included in the flap design. Now that all the teeth have been restored, now that anesthesia has to be made, you measure the gingival recession at the level of the canine. You measure it with a probe. Then the same distance is measured starting from the tip of the papilla. And what I can suggest you is to mimic with your blade the right inclination of your submarginal incision, starting from the most apical extension of the gingival recession of the adjacent tooth towards the canine. And in order to have this line visible when you are going to use your knife, you can make a small pressure with your probe along this line, so you have a guide where to make your incision line that should follow this small impression that you have made with your probe. And this is repeated for every single tooth, including the flap design, namely you measure the depth of the gingival recession, you mimic how the submarginal incision should be made, you make a small pressure with the probe on the soft tissue, so you can really appreciate very well where you have to perform your submarginal incision. And this is, again, repeated for all teeth included in the flap design. Now that you have the guide, you can take your knife, and with the tip of your knife, you just sign the bleeding line, which means the submarginal incision line, which gets from the gingival recession of the adjacent tooth towards the canine, and the same is done at the level of the adjacent teeth, so that with a series of 5 submarginal incisions, you really complete your flap design from 1 to 6. And this is done only by making the bleeding line from the most apical extension of the gingival recession of the molar to the most apical extension to the gingival recession of the central incisors. Now that the design has been made for all surgical papilla, you have to elevate it. And remember that in this case, you cannot make any mistake in the tip. The tip must be preserved in its thickness, epithelium, and connective tissue thickness. So you get inside this incision line, you turn your needle, your knife, go intracircularly until the all surgical papilla is elevated with the same thickness you get at the level of the tip. Split thickness elevation of the papilla ends at the base of it, namely at the imaginary line connecting the soft tissue margin of the 2 adjacent gingival recessions. So we can see it closer. You can get inside. You can get back to this incision, and you use only the tip of the papilla horizontal to now elevate the tip from the intracircular incision to the submarginal incision. And once the tip can be placed above your knife, namely you have conquered, this is the tip, you can go horizontal and give the surgical papilla all the same thickness. You see that the thickness of the papilla is not epithelium only, as a good thickness of a connective tissue, so it means that it will survive once it will be placed above the anatomic disepithelialized one. Now, all surgical papilla, 5 and 6, 5 and 4, 3 and 4, 2 and 3, and 1 and 2 has to be elevated split thickness. Now it's time to take the periosteum elevator. And in order to choose which tooth to start with the full thickness elevation, you have to start with the tooth with a greater amount of keratinized tissue remaining, so it's much easier for you to elevate full thickness this tissue. So you start at the level of the lateral, for example, until you reach the bone crest. You overcome it, and that's all. Then you go to the central. Then you go to the 4 or 5. But only the last tooth is the canine, because the canine is the tooth with the smaller amount of remaining keratinized tissue. Full thickness flap elevation must be made in order to elevate full thickness also the mesial root of the molar and the central incisors. And you have to see the bone crest in all teeth included in the flap design before starting with the split thickness elevation to make the flap free from muscles. Now we have to make full thickness elevation at the level of the canine. Until you reach the bone crest. Once the bone crest is reached, you go further apical for 1, 2, 3 millimeters, and then it's enough. Now the all keratinized tissue is elevated full thickness, and now it's time to make the flap corneally advanced. And what you can do in order to facilitate what you are doing is to use a probe. With the probe, at this time, if you try to go parallel to the lining mucosa of the lip, you cannot do it. The probe is interrupted in a specific area, which is the area where the submucosal tissue is inserting onto the periosteum. And so with a probe, you cannot reach the submucosa, the lining mucosa of the lip, because there is still to do first the deep incision parallel to the bone. So now I have to detach these muscles inserting on the periosteum by making a deep incision blind only with the tip of your knife that is following the bone with the bone surface in order to cut precisely from the soft tissue of the submucosal tissue to the periosteum. So the first incision, it's a blind incision made with the knife blade completely parallel to the bone until you see that the submucosal tissue, and in particular the lining mucosa of the lip, detach from the bone level. Please look at here. Once the deep incision is made, and you try now with the same probe, you will see that now you are able to go parallel to the lining mucosa of the lip. You see? It means that now you can go superficial. So if you follow these steps, it becomes really much, much easier. First of all, you cannot make the deep incision until you can do with a probe, and if you can do with a probe, you can do also with your knife and make the superficial incision. You see that the periosteum is left there, and now you have to remove the muscle from the inner aspect of your alveolar mucosa. So you go superficial, and in this case, you start to see the movement of your blade by the very transparent and thin lining mucosa moving inside the soft tissue, because you are getting rid of the muscle from the superficial lining mucosa. In this way. So when you make the deep incision, the bone is placed above, the knife is placed above the bone. When you make the superficial incision, your knife is applied in the inner aspect of the alveolar mucosa and is moving toward the middle until you remove with a very nice, with very new cutting edge knife, all muscles insertions you find from your mesial distal movement. You see the movement of your blade, and there should be any interruption. You have to do still the distal aspect. The mesial is okay. So first of all, deep, parallel to the bone, parallel to the bone, parallel to the bone, in order to detach the submucosal tissue, and this has to be done also distal to the forcation area, parallel to the bone, Now you check with the probe, yes, I can go parallel to the lining mucosa, so I can go superficial and start applying my knife in the inner aspect, very superficial, of alveolar mucosa from mesial to distal. There should be any interruption when I move the blade in this direction, keeping the blade in touch with the lining mucosa. You see it? It means that everything is completely now free from muscles. But remember that there are still two areas to work on. One is the interincisor papilla, and one is distal to the furcation. In the interincisor papilla, I have to make what we call hemitunnelization. Namely, you have to get rid of the soft tissue in the interincisor papilla from muscles without the need of making a split thickness incision at the level of the papilla. So first of all, with your knife, you go parallel to the bone towards the interincisors papilla, deep incision. Then you get even more horizontal. You have to go, if there is a frenulum below, the deep insertion of the frenulum, very, very deep, parallel to the bone. This is the first incision you have to make. And once the alveolar mucosa is detached from the bone level, you can change the inclination and becomes superficial. So again, two incisions has to be made also in this area, one deep towards the interincisor papilla and one superficial. And what does this allows you to do? To make this surgical papilla between the central and the lateral rotated mesial and cover completely the anatomic papilla at the same time, cover the gingival recession of the central and lateral. Look at, I pull it in coronal direction, and when this rotate, this cover the gingival recession on the central and the lateral. Now the same thing is done at the level of the molar. There is still some tension here, so you go distal to the furcation area by making first the deep incision parallel to the bone, parallel to the bone. Then you can detach the alveolar mucosa from the bone level and make the superficial incision, and this will allow the surgical papilla between the molar and premolar to rotate and cover both the mesial root of the molar and the distal aspect of the premolar. Now the flap is ready, because every single surgical papilla can be displaced above the corresponding anatomic papilla. Now it's time to make root planing, and you always have to remember that the probing pocket depth plus gingival recession. You see the gauze applied apically. I'm protecting, I'm reducing blood clot, I'm reducing the bleeding, I'm exposing the area where root planing has to be made. And if there is area apical to the probing pocket depth that was not probable before the surgery, this has not to be made any root planing. Mini 5 curette are used in order not to change the shape of the root, because I don't want to flat it. If you flat it, you reduce the number of dentin tubuli that will join with the blood clot during the time of the healing. So you try to maintain the same shape of the root, but root planing must be performed until a very smooth, hard root surface is achieved. It is the noise of the dentin when you use the very sharp curette that tells you that now the dentin is really clean, is without any demineralized and softer tissue left. After root planing, you apply ADTA gel, always to remove the smart layer, while Hendogain has to be applied only in those situations in which there is a very buccal dislocation of the root or very, very wide and deep root exposure, and you want to improve the quality of the attachment. Now it's time for the desepithelialization of the anatomic, and also the desepithelialization of the anatomic papilla, must be made with your knife, following the same line of incision which was made to prepare the surgical papilla, but in this case, only the epithelium must be removed. The base of this papillae must be desepithelialized with the use of the blade. Now there is the suction ready to wait for the epithelium to be turned in occlusal direction, and so it's very easy now to see the surface which was followed by the knife that now is followed by the microsurgical scissors until the whole epithelium is removed up to the tip of the papilla. And this has to be repeated, obviously, for all surgical papilla, including the flap design. First of all, knife, now suction, in order to see what is the cutting surface prepared with the knife blade, because you don't see the epithelium anymore, and now you complete the suction by using the microsurgical scissors. Now all the papilla have been prepared, and it's time for suturing. And to suture this flap, it's much easier than that with the vertical releasing incision, because you only have to use sling suture. But it's very important to start at the right point, which is the papilla between 6 and 5. So you place with the pincette the papilla between 4 and 5 in position. And since you made the right flap design, the papilla between 6 and 5 goes above the anatomic papilla passively. And once the papilla reach the final position, it's time to make the one-shot perforation, surgical, anatomic, and palatal papilla. So now you can leave with the pincette the papilla between 4 and 5, and take the papilla between 3 and 4 in position. And once the papilla between 3 and 4 is in position, the papilla between 4 and 5 will be in position if you make the right design, and so you can make one-shot perforation of surgical, anatomic, and palatal papilla. Now you go back to the starting point with the back of your needle, and you start to pull it until you see ischemia of the keratinized tissue, and now you can close only one knot for placing 2 papilla in the right position, and in such a way all from the molar to the first premolar is completely stabilized with no blood getting out from the soft tissue margin. The second sling suture, the first one is the distal one, the second one is the most mesial one. So the last one is the canine, because it's the tooth where you made much more coronal advancement. So you take with a pincette surgical papilla above the anatomic papilla between lateral and central, and at the same time the papilla between central and lateral goes in position. So you make a perforation of this papilla, surgical, anatomic, and palatal. And now you take anchorage at the interincisors tip of the papilla, which was never elevated, so it's a perfect anchorage for your coronary advanced flap. And so you just make in the middle a perforation of this papilla. You go back to the starting point with the back of your needle, and now you can pull this, you can close this, and you can achieve a perfect coverage and good adaptation of the keratinized tissue to the convexity of the clinical crown of both the central incisors and lateral. At this time point, with only 2 sling suture, 2 knots, also the canine, which had a very, very deep gingival recession, is almost in the final position, so you will suture it with no tension at all. What you have to do at the level of the canine, obviously, is the last sling suture. You can start whatever you want, mesial or distal, doesn't matter too much. Surgical, anatomic papilla, palatal papilla. Then you go back with the back of your needle, mesial, with no perforation. Now you make a perforation back, surgical, anatomic palatal, around the palatal cingulum, go back at the buccal, pull it, tight it in order to see compression of the surgical anatomic papilla, ischemia of the keratinized tissue above the convexity of the clinical crown, which was restored by means of the composite restoration. And once everything is stable, you close it. And that's why it's very important to use this suture, because when you pull it and you see ischemia and you make the second knot, this remains stable. If you do with the monofilament, during the time it takes for prepare the second knot, it relapses. And so you have to start back. And so it's something that I don't like when you use such a very thin, very, very limited amount of soft tissue to handle with, that you continue to change the tension of your knot by using elastic type of suture material. This is not an easy material to be used, but it's extremely soft. It's a female suture material. It's not a man suture material, you know. Now you have to check for half an hour. The patient remain in your office with some ice applied locally, and after half an hour, you have to check your patient back that there shouldn't be any blood seeping from the soft tissue margin, because blood clot stability is even more important for the treatment of multiple than single type of gingival recession. You see that there is no, even in the occlusal aspect, you don't see any sign of bleeding getting out from the soft tissue margin. And also the occlusal aspect tells you that each keratinized tissue is well adapted to the convexity of the clinical crown, so this will be stable during the healing outcome. So just to summarize, split thickness elevation of the surgical papilla. Remember that this has to be done in order to keep the tip of the papilla with the right thickness epithelium and connective tissue. Full thickness elevation of every single tooth included in the flap design. First of all, deep incision to remove the muscles from the periosteum. Then superficial incision in which you check the movement of your blade by transparency. Then the flap is ready to be corneally advanced. Disepithelialization of all anatomic and surgical papillae. Start distal. The first suture is the distal between molar and premolar. The second is the mesial between the lateral and the interincisor papilla. And the last one is that one between around the canine. The outcome, you see that there is really no sign of the surgery. The keratinized tissue is increasing, the thickness is increasing, but in order to better see the thickness, as we saw yesterday, you have to see the profile of the tooth with replacement of true convexity thanks to the maturation of the blood clot. And this is what we said yesterday. Remember that if no composite restoration, it was not possible to achieve sudden increase of soft tissue thickness because of the risk of collapse of the soft tissue if you leave a very sharp interruption of the enamel in a too much coronal position. The coronally advanced flap for multiple gingival recession, it's not only a root coverage procedure, but it's an HS flap, in the sense that the need for a connective tissue graft to be adjunct should be evaluated cytospecifically for all teeth included in the flap design. Obviously, if you don't have any problem in terms of quality of the keratinized tissue, in terms of deep of the abrasion defect, prominence of the root, we will use only the coronally advanced flap. But if some, 1, 2, 3, depends on the gingival recessions that are treated during the multiple type of envelope of coronally advanced flap need, for the same reason we have already said, to adjunct a connective tissue graft, this has to be done cytospecifically. And this is one of these examples. All the abrasion defects were restored with a composite restoration before surgery. You see that this was done at the level of the molar tooth, premolar teeth, and canine. You see that according to which type of restoration and which type of surgery we will select to use the coronally advanced flap only or to adjunct also a connective tissue graft. The emergency profile has been restored, and this is the situation before surgery. As we said, we have the two teeth at the periphery. We have the midline passing through the canine, has a line around which the papilla will rotate. We measure the recession of the canine, same distance, two submarginal incision, premolar, submarginal incision from the second premolar also mesial root of the molar, and finally the very small gingival recession of the lateral, which is reported to treat also the central incisors. What we said is that all surgical papilla that are created by this submarginal incision during the coronal advancement of the flap will rotate towards the periphery. All the surgical papilla distal rotated distal, all the surgical papilla mesial to the midline rotated mesial. Each surgical papilla will be elevated split thickness. The all keratinized tissue will be elevated full thickness, and then again we will have a split thickness elevation, more apical, and this split thickness elevation will be completed with the desepithelialization of the anatomic papilla. The deep incision is used to remove the muscles from the periosteum. The superficial incision is used to remove the muscle from the inner aspect of the alveolar mucosa. Remember that we have also to make the hemitunnelization of the interincisor papilla, so you have to go split thickness, more mesial than the central incisors, and this has to be done also distal to the molar tooth. So now we measure the canine after composite restoration. We measure the premolar. We look at the quality of the keratinized tissue, the prominence of the root, and we will apply cytospecifically only where it is really necessary the connective tissue graft together with the coronally advanced flap for multiple type of gingival recession. Now that the probe have designed this line, this line is followed by the blade. This is the microblade I was telling you yesterday, which is very, very similar, exactly the same in the tip to the 15C blade, but it's narrow. This is very good to create the good tip of the surgical papilla, but it's not as good as the 15C blade in order to make the desepithelialization of the papilla, to make the desepithelialization of the graft, the split thickness elevation, apical, in order to remove muscles. When you have these probes at the level of the papilla, and this sometimes happens in patient brushing a lot, this is very dangerous because this is an invagination of the epithelium you have along the papilla. And so if you are too much thin in elevating the papilla, this is only epithelium, and you are going to lose the papilla during the surgery. So this is a very nice papilla with no probing inside, while this is a papilla with one small probe here, which is an invagination of the epithelium. And in that area, during the split thickness elevation of your surgical papilla, you have to be very, very careful to keep intact also the thickness of the connective tissue. So this is the elevation of the second surgical papilla, split thickness up to reach an imaginary line which is connecting the soft tissue margin of the two adjacent gingival recession. Also, you have to go split thickness distal to the forcation area when you have to cover also the mesial root of the molar. So split thickness incision mesial at the level of the forcation, and split thickness incision at the level of all teeth, including the flap design. Then it starts the full thickness flap elevation. It starts at the level of the tooth with greater amount of keratinized tissue remaining. So first of all the premolar, then the lateral, then we get to the canine, and finally to the premolar, which is the tooth with minimum amount of keratinized tissue remaining, much more buccally dislocation of the root, together with the canine. Full thickness flap elevation must be done also at the level of the central incisors and at the level of the molar tooth, in order to cover both the gingival recession at the level of the central incisors and at the level of the mesial root of the molar, without the need to extend ever the split thickness papilla between the two central incisors or between the molar and the second molar. Now I have to look at the bone crest. This is the full thickness elevation at the level of the central incisor. And this is the full thickness elevation at level of the buccal surface of the molar. This is the deep incision. This is an incision parallel to the bone. Remember, this is used to detach the submucosal tissue from the periosteum. You have to be very careful to follow with your knife blade the shape of the bone. Now you can check with your probe that you can go superficial, and now you are applying your blade in the inner aspect of your alveolar mucosa, and look by transparency the movement of the blade through the very thin and transparent lining mucosa. Now the flap is ready. This is the deep incision, parallel to the bone, parallel to the bone, parallel to the bone, in order to detach the submucosal tissue from the bone. And once you see that the alveolar mucosa is detaching, you can go with your probe, and so also with your knife, much more superficial, and start with the superficial incision parallel to the lining mucosa of the lip. Now we have to make some tunnelization of the interincisor papilla, starting with a split thickness incision apical to the keratinized tissue, in order to make the papilla between the central and lateral rotate a bit to cover the very small gingival recession on the central. While, since you have to cover also the gingival recession of the mesial root of the molar, you have to go more apical, more distal, with the deep incision first, and then with the superficial incision, because by means of the rotation between the papilla, between the molar and premolar, you will cover also the mesial root of the molar. Now that the flap is almost ready, this is the superficial incision distal to the forcation area, to make this papilla very, very passive rotate. Root planing, mini 5 curette, until a very smooth and hard surface is obtained. All roots must be clean. Obviously, in this case, we have also the mesial root of the molar, the ADTA application to remove the smart layer. This has to be left in place for 2 minutes under a good control of the bleeding. Then you rinse a lot, and if you have a very buccally dislocated root with respect to the bone, you also apply amelogenins that will improve the quality of the attachment between the soft tissue and the hard tissue. Now, you start with the desepithelialization of the papilla by using the small blade at the base to prepare the cutting surface to be followed by the small microsurgical scissors. Now the suction arrives. You see the surface very, very clear. And now you can follow this surface with the microsurgical scissors until you reach the tip of the anatomic papilla that can be such easily desepithelialized. Again, desepithelialization of this wider papilla at the base. With a knife, and then with the microsurgical scissors. There is some instruments, obviously, you have to have in order to perform this kind of surgery, and these are the needle order, which is unique to be used with the 7-0 small needle, which is the microsurgical scissors, and some periosteum elevator that you cannot find, because every single periosteum elevator should be selected cytospecifically in order to elevate full thickness only the keratinized tissue apical to the gingival recession, and so it should not be too wide, it should not be cutting, it should be very smooth in order to elevate the tissue without creating any trauma to the keratinized tissue. Once you decide to make to make a connective tissue graft at the level of the canine and premolar, since the cemento enamel junction of the canine and the premolar are located in two different areas, you don't have to take one graft only, but you have to take two different grafts, because each of them must be applied cytospecifically at the right place, following the outline of the cemento enamel junction. And you know that the cemento enamel junction of the canine is more apically dislocated with respect to the cemento enamel junction of the premolar. So if you apply the graft at the level of the cemento enamel junction of the canine, it's too apical for the premolar. If you apply at the level of the premolar, it's too coronal for the canine. So two grafts, both of them should be desepithelialized. You see, this is a very modern type of using this graft. The graft is only 4 millimeter high. It does not reach the most apical aspect of the bone exposure. It's extremely thin. We are speaking now today about 0.6, 0.7 of a connective tissue graft, so the wound area in the palate is really minimum. This is really minimally invasive surgery, because if you use other technique in which enormous amount of connective tissue graft has to be taken, even if there is less, let's say, muscle dissection at the buccal surface, this doesn't mean they are minimally invasive, because the problem and the pain for the patient is not at the buccal surface, but it's always when you take the graft from the palate. And as much as you can reduce the trauma in the palate, the more minimally invasive you really are for your patients. So this is the first suture we have already seen. This is done with the bigger suture. This is 11 millimeter needle. Otherwise, you don't reach with the 7 millimeter needle the palatal aspect. And the first knot is closed at the level of the molar tooth, because you have also to cover, remember, the gingival recession, which was present as the mesial root of the molar. And with this suture, you create a double compression, a double adaptation of the surgical above the anatomic papilla. Now you have to close the canine. The central incisor has already been closed by anchoring the papilla between the lateral and central incisors to the inter-incisors papilla, which was never elevated. And so again, with a very simple surgery, you're able to achieve good coverage of all gingival recession, including the flap design. Let's say about half an hour later, you check for the patient. There should be any blood escaping from the soft tissue margin, a very good adaptation of the keratinized tissue to the convexity of the clinical crown of each tooth. And also, after half an hour, you check for the palatal wound. You see that neither the material is red, it's still white. It means that there is no bleeding at all, because the healing is so rapid, because there is no really exposure of the submucosal tissue, the periosteum of the palate, which create more pain but also more bleeding. So remember that what we have to do, just to remind, a single step, full thickness flap elevation must be done at the keratinized tissue, split thickness, first of all with a knife parallel to the bone, then with a knife parallel to the soft tissue. The connective tissue graft should be applied cytospecifically. They should not be extended at the level of the bone. They should be only 4 millimeter height, 0.7, 0.6 millimeter thick, should be applied at the level of the cement enamel junction. If the cement enamel junction of the two teeth is displaced in two different levels, you cannot use the same connective tissue graft for both teeth. So two different types of connective tissue graft should be used, but in all situations, it is the flap that is going to be applied cornal to the connective tissue graft. So the connective tissue graft is used in a more submarginal position with respect to the connective tissue graft, and the healing in terms of aesthetics depends on the Corneal Advanced flap. And this is a 15 days removal. You see that you don't see any sign of the graft. The flap is completely covered the root, and you don't see the difference between the teeth that was treated with or without the adjunct of the connective tissue graft. And this is also in the medium and long-term outcome. You don't see any sign or difference between the three teeth that were treated with or without the adjunct of the connective tissue graft. And also when you compare before and after, you see that there is really increase of the keratinized tissue height with no sign of the surgery. If you want to see where the graft was placed, you have to make the profile of the teeth, and you see that the increase in the soft tissue thickness is much more at the level of the canine, is much more at the level of the first premolar, which were the teeth with much more buccal dislocation of the root, deeper root abrasion that now was completely treated by means of the composite restoration plus Corneal Advanced flap and connective tissue graft. And this is the profile, the final profile of the canine. If you want to see before and after with the slipping tooth, you see the abrasion defect, prominence of the root. Now you increase so much the thickness of the soft tissue, you cover also the cement enamel junction, and you don't see any difference in color because there is no sign of graft exposure. And this is the comparison between before and after. And also in teeth with deeper gingival recession, deeper root abrasion, it's very important to combine the restoration with the mucogingival surgery in order to replace good emergency profile. Exactly what we did yesterday. The patient does not know that some of this aesthetic outcome depends on this amount of composite restoration, and the rest was done with the soft tissue, and the same is for the canine. What the patient should be aware of is that there is some enamel to be replaced and some soft tissue to be replaced, so we will use some enamel to replace the loss of enamel, and we will use some soft tissue to replace the lost soft tissue. And also the molar tooth, which had gingival recession, abrasion, is restored with a combination of composite restoration and soft tissue increase, even without the need of any connective tissue graft, because in this case we have a good abrasion of the root, good quality of the keratinized tissue, so you have a good increase in the blood clot, and so good increase in the soft tissue thickness, even without the need of any connective tissue graft. In the lower jaw, treatment of multiple gingival recession is divided in 3 sections. One is used to treat from the mesial root of the molar to the canine on one side. On the other side, if you have gingival recession on all teeth, and the last area to be treated is that one between lateral and lateral. The reason why we divide the treatment of multiple recession in the lower jaw in 3 surgery with respect to the upper jaw that is divided in 2 surgery from 1 to 6, is because of the greater need of connective tissue graft in the lower jaw with respect to the upper jaw. And so, since most of the teeth you treat in the lower jaw needs to adjunct the connective tissue graft because of the shallow vestibulum depth, because the low amount of keratinized tissue, because the presence of frenuli, because the presence of big and strong muscle pulling the soft tissue in apical direction. And so you have to divide more, you have to make more surgery in the lower jaw because you cannot make connective tissue graft for all teeth from 1 to 6, because the maximum number of teeth you can treat with the connective tissue graft does not exceed 3 or at least 4 gingival recession. The second reason why in the lower jaw you have to treat the incisors in a different surgical setting with respect to the area of the canine, premolar, and molar is because the area of the 4 incisors does not have such a big papillae, anatomic papillae like you have in the upper jaw, that you can make them rotated even without making any incision, like interincisor papilla, but the papilla is much smaller. And so in the area of the lower incisor, which is the most difficult area to be treated in all mouths, you have to use a trapezoidal type of flap approach. For multiple gingival recession, you will make 1 vertical releasing incision distal to the lateral, the second vertical releasing incision distal to the lateral, and all horizontal trapezoidal surgical papillae included, because the blood supply between surgical and anatomic papillae in the area of the lower incisors is so critical because of the presence of very narrow, very small anatomic disepithelialized papilla. So we will see 2 different approaches in the lower jaw. One is the posterior approach from 6 to 3 with all incision from 6 to 3 converged toward the canine, exactly what we said in the upper jaw. But this flap is interrupted from the canine to the lateral because the lateral has to be done in the frontal area with only 1 vertical releasing incision mesial to the canine. You see which is the problem in the lower jaw. The lip is completely horizontal. You have the emergency of the nerve, which is about 4 to 5. After making anesthesia, you see that the swelling from the swelling of the lip, that there is no attached gingiva at all. There is no alveolar mucosa at all, but it's only lining mucosa of the lip. So the area is much more difficult to be treated. And so, first of all, we have to make 1 vertical releasing incision in keratinized tissue. Remember that every single time you don't have any keratinized tissue, what helps you to give stability to your flap is to place keratinized tissue at the level of the surgical papilla. And which kind of surgical papilla we make? Obviously, it is a trapezoidal type of surgical papilla because we have to add a connective tissue graft to these teeth. And so we don't want to make only triangular type. The other flap, since you don't make any vertical releasing incision distal, it's a multiple type of approach, exactly the same we have seen in the upper jaw. All submarginal incisions are directed towards the canine, from the premolar to the canine, from the second premolar to the first premolar, and from the molar to the second premolar. So in this way, you will be able to treat also the premolar and also the mesial root of the molar without the need to make a vertical releasing incision distal. But mesial, it's necessary, absolutely necessary, because we have to avoid in this area to make the deep incision parallel to the bone. Deep incision parallel to the bone that we make in all other areas of the mouth, that is used to detach the alveolar mucosa from the periosteum, cannot be made in the area of the premolar because of the presence of the emergency of the mental nerve. So you have to make something different in this area from making your incision with a knife parallel to the bone to detach the submucosal tissue. And now we will see what you have to do. Now we are preparing split thickness surgical papilla of different shape, triangular between the premolar and canine, trapezoidal mesial to the canine. Since you don't have, when you don't have any keratinized tissue remaining, the alveolar mucosa is invaginating, is becoming probable at the buccal surface of the teeth. So you cannot use the periosteum elevator to detach this alveolar mucosa that is invaginating in the sulcus area. So you need a very small submargin, a small intrasulcular incision that is necessary for you to detach this alveolar mucosa that is invaginating in the sulcus and being able to elevate it full thickness. When you have keratinized tissue, you can use directly the periosteum elevator, and this is what I will do in the keratinized tissue of the 5. But if you don't have any keratinized tissue, you cannot use the periosteum elevator because the alveolar mucosa is not stable enough, is not strong enough to resist the pressure of the periosteum elevator, but you have to make an invitation with the knife to more apical to insert your periosteum elevator. So now I'm preparing the second disepithelialized, second split thickness surgical papilla. Again, you should be very careful to give the right thickness to the tip of each surgical papilla. Everything in the lower jaw, it's much more difficult. Because of the tension of the lip, because the pull of the muscles, and because of the minimum amount of keratinized tissue remaining. You see that the lip is completely horizontal, so you don't have vestibulum depth. Okay, now all surgical papilla has been elevated. You start with the full thickness, and you can use the periosteum elevator directly in the sulcus, where you have still some amount of keratinized tissue, which is the 5 and the 6. But here, you will see that this lining mucosa has to be detached from the root surface before being able to apply the periosteum elevator and expose the bone crest. And the same has to be done in the canine, because you see the invagination of the alveolar mucosa that is completely attached to the surface of the root that has been detached from with the blade, and only once. Look at how attached it is. This is the inner aspect of the alveolar mucosa that has to be detached from the root, and then you can use a periosteum elevator to expose the bone crest. Now, what is the difference? You cannot make deep incision. In this time, the muscles are against the periosteum, but these muscles are can be really changed in their orientation towards the periosteum. In this moment, they are almost parallel, very, very close to the periosteum. Now, what I can do is to force these muscles by using a gauze that compress the flap in apical direction and accompany my flap towards the lower board of the mandible to make the muscles below my force healed, so that once they will be open, I will see muscles inserting horizontal from the alveolar mucosa to periosteum, and I will cut only the superficial insertions. Look, now you take a gauze, and with your fingers, you apply a force in apical direction, and during the force, you feel the muscles of the lip healed under the pressure of the gauze. You really feel these muscles that does not react anymore to your pushing maneuver. Now you check what we have done. And what we have done is something that is very safe for the nerve, but it's also very useful, because now you see that the muscles and the submucosal tissue, instead of being attached to the periosteum, has been separated. And when you take your surgical papilla towards the, again, on the opposite direction with respect to the periosteum, what do you see here? There is enormous space between the surgical papilla and the periosteum. And this space, which is very wide, it's about 4 to 5 millimeters, is occupied by muscles that inserting horizontal on one side to the periosteum and on the other side in the inner aspect of the alveolar mucosa. And obviously in this area, since it's very dangerous to make split thickness incision parallel to the periosteum in the premolar area, you only make superficial incision. So of the two insertion, this is the deep. You cannot touch it. You cannot touch it. You have to leave the muscles there. You will make only the superficial incision. You see that my incision can be made directly parallel to the lining mucosa of the lip without the need to make any deep incision first. You see, muscles, horizontal, you can cut only superficial. Muscles, superficial. You can see here, this is the muscles. This here, it has already been done. Now I have to do this area of the first premolar, and we cut superficial, so the muscles will go towards the periosteum and will leave my lining mucosa completely free from muscle to be cornea advanced. So the risk to cut the nerve when you make such a superficial incision is absolutely nothing. You see here, it's very clear, deep in superficial, deep incision. At the level of the canine, yes, you can make mesial to the canine, there is no problem. Distal to the canine, it's a bit risky, because if the emergency, it's at the level of the 4, remember that the very superficial, some of the ramification of the nerve can get coronal and mesial. And so mesial to the canine and the central and lateral incisors, there's never a problem. But distal to the canine, I never make deep incision, because distal to the canine, it's always an area that can be dangerous. But in general, I never make deep incision also at the level of the canine. I always avoid to do it so that there is no problem, even in those cases in which, for example, the emergency of the nerve could be mesial to the first premolar. And so also in this area, I don't make deep incision. In this case, just to show you the difference between superficial and deep. This is the superficial. It's very, very clear. No risk at all. This is a very difficult area because of also the presence of the emergency of the nerve. And with this approach, by means of the use of the gauze, you can clearly see the difference between the superficial and deep. Once the flap was completely attached and we were almost in this situation, look at the beginning. How can you distinguish it? How can you distinguish after the full thickness flap elevation? How can you distinguish which is the superficial and deep? They are too close. And so it's extremely dangerous to go with the knife between the two. So you have to open them with the gauze, and then you see very, very clearly the difference between superficial, because there is an area of about 4 to 5 millimeters in which the muscle becomes horizontal. Okay? Now, where we are here. So we are getting free from muscles in the area of the canine. And you will see that after removal of the all muscles at the level of the lining mucosa of the lip, this alveolar mucosa becomes mobile and can be advanced corneal with no problem at all. Now it's time to take the gauze to compress the flap in apical direction. You see that the muscles remain covering the periosteum, and so the emergency of the nerve, while your alveolar mucosa is completely free from any muscles. Now it's time to make root planing. If there is some area which is particularly rough or irregular, you can also use some composite shape diamond bar in order to finishing it, but all times you use a bar, you always have to make manual root planing with a curette in order to have the feeling that the dentin is really hard, smooth, and clean. Because with the diamond bar, you can feel a surface hard enough, but when you use the curette, there's still some soft tissue to be removed. So diamond bar instrument can be used only for big, very, very rough surface irregularities on the root, especially, for example, if a composite was already made too much apically on the surface that has been removed. In this area, you can use some diamond bar in order to remove the excess of composite material, adhesive material, but then you always have to make your manual instrumentation on the root in order to achieve a very clean and very smooth root surface. Again, some use of diamond bar in this area, which was really very, very concave, but always it is finished with manual instruments. Composite restoration can be also clean and polished with the use of some rubber point intrasurgically in order to achieve really a good emergency profile at the level of the new cement enamel junction in the case you have some irregularities or you have a too much bulky profile of the composite restorations. So this is the only instrument you can use on composite is this rubber point. No, you can use the diamond bar anymore because you don't want to reduce too much the material that is critical for the success, long-term success of the restoration. Now it's time to apply ADTA, and obviously we have such a buccally dislocated root that in this situation for the canine and premolar it's indicated also to use amelogenins and improve the quality of the attachment. Now everything is prepared for the desepithelialization of the papilla. This is the amelogenins application. This is left in place about 1 minute, and then you don't care about the destiny of the gel, because the gel does not contain cells, but the gel only contains proteins, and once they've been deposited, you don't have to do anything else. The use of Endogamine is not at all a substitute of a connective tissue graft. The connective tissue graft should be used to increase the thickness and to give stability. Endogamine should be used only to improve the quality of the attachment. This is a completely different story. So sometimes you use the Endogamine with no connective tissue graft, and sometimes, most of the time, you use the connective tissue graft with no need to use the amelogenins. This is the desepithelialization of the anatomic papilla with the blade first and then with the microsurgical scissors. And now you go to the palate. In the lower jaw, There is less difference with respect to the upper jaw between the position of the cemento enamel junction of the canine and the premolar, with respect to the upper jaw, where the canine is much more apically dislocated with respect to the premolar. So if you take the good quality of the connective tissue graft, you can place the connective tissue graft using this quality of the connective tissue graft that can achieve different shape, as we saw yesterday, for both teeth. What is the advantages of taking only one graft with respect to two grafts? Is that it's more easy to desepitalize, it's more easy to suture, and it's more easy to be taken from the palate because it's bigger. While what is the advantage of two grafts instead of one? That can be applied cytospecifically when there is some disalignment, very clinical, significant disalignment of the mucogingival line. Every single time you can, it's better to use only one graft because it's easier, but if they are very much dislocated, you need two grafts, as we saw in the case of the upper jaw. In the lower jaw, the cement enamel junction of the canine and premolar is much more similar with respect to the upper jaw. And so in the lower jaw, most of the time, we can make only one graft that will be sutured at the two different levels, as we will see later, by using the very small needle and placing the knot in the right position. I insist with you to say the importance of placing the knot in the right position, because it's critical for the success of the surgical procedure. And if you want to use, and if you want to facilitate the position of the knot, you have to use this kind of suture, which is not elastic. And once the knot is placed, you can leave it in the same position. The reason why I used in this specific area the periosteum elevator, because there was some bone esostosis, brava, it's like esostosis in the palate, and so if you meet some esostosis with a knife, you have to be very careful to get over to the esostosis with the periosteum elevator and not with a knife, because if you get with a knife, the risk is to thin too much the connective tissue in that area and leave only the epithelium. And so where there is esostosis, the thickness of the connective tissue is small, and the whole thickness must be kept. If the esostosis you can find after removal of your frigigingival graft is very, very big, you can also make perforation on it in order to improve the bleeding and improve also the quality of the healing. You see that also in this case, the bleeding is really nothing. You can see here the small area of esostosis. It was so minimum that it was not necessary to make it bleed, and so it was much easier, much more comfortable to make the stabilization of the substitute of the connective tissue graft and the cross suture to stabilize it, and remember also to place the knot in the most apical and distal. So now you fix the knot, apical and distal, you know. Once it is fixed, it is tight, you make a ligature, you can close the second one. This is a substitute of collagen. You can use whatever you want. Everything is effective, because the only rule of this, obviously, it's not to increase the keratinized tissue, because in the palate we don't have any problem in the keratinized tissue, but just to improve the wound by accelerating the stability of the blood clot, and so reducing the bleeding and improving the comfort of the patient. Now it's time for the desepithelialization. You see there is only small area of yellow, fatty, and glandular tissue to be removed. I always remove the yellow, fatty, and glandular tissue because I don't want to leave any mobile soft tissue above the root, and the fatty tissue is a tissue that is not good for achieving root coverage, and the same is for the glandular tissue. So first of all, I prepare the inner aspect of the graft, and then I start with the desepithelialization that you have already seen many, many times, how it is important to prepare the surface with no remnants of the epithelium. After desepithelialization, everything is ready, and you see that there is some, not so much, but there is some disalignment of the mucogingival line of the cement enamel junction, but you see that this type of graft has the capability to change the shape according to where it will be sutured. So it is very important to suture the mesial aspect of the graft at the level of the cement enamel junction of the canine by fixing the knot at the level of the graft. Then you suture the distal line angle of the canine with the same procedure in order to make the graft following the curved scalloped outline of the cement enamel junction at the level of the canine. So the second you make is at the line angle, distal line angle of the canine, base of the anatomic desepithelialized papillae with this very small needle, and then the last suture is done at the distal line angle of the premolar, trying to give to this amount of graft a more flatter surface, because the surface, the cement enamel junction of the canine, of this premolar, is more flat than the cement enamel junction of the canine. And you see that this graft, but only this graft is able to give this different shape in two different teeth. If you want to do the same type of remodeling of the graft, with the graft you can take with the single incision technique, you will never succeed to do it. Graft is something that is a more abstract shape. You see that the graft is following the cement enamel junction in two different teeth, even if there is some dislocation. If the dislocation is much bigger, and you have to take two different grafts, as we did in the upper jaw of the case before. Now, there is another difference in the lower jaw with respect to the upper jaw, and that is that it's much more difficult, and always, since you don't have enough gingiva attached to the adjacent teeth, you have to take periostal anchorage suture. Because here, you have to fix the most apical extension of the vertical releasing incision to the alveolar mucosa of the adjacent tooth. And it's very important to get the periosteum along this suture in order to stabilize the vestibulum depth, again, after surgery. So you have always to make periostal anchorage suture in the most apical extension of the vertical releasing incision in the lower jaw, which is not true in the upper jaw, because it depends on how much keratinized tissue do you have and attached gingiva do you have. In this suturing, you get the periosteum, you close the knot, and you start to stabilize the most apical aspect of the vertical releasing incision. First, you have to close the vertical releasing incision, and then once the vertical releasing incision is closed, you can suture surgical papilla, anatomic papillae. Since the flap have the tendency to go distal, especially in the lower jaw where the muscle pull is stronger, you always have to fix the surgical papilla between the canine and the lateral to the anatomic papilla, which has never been treated between the two incisors. So you go mesial, you perforate it, you can back, and you close. So in this way, this surgical papilla will be adapted above the anatomic papilla, but also more mesial, in contrast with the tendency of the flap to go too much distal. And that's why it's important to have a trapezoidal papilla, because here you have still some tension. Now you have an envelope type of flap, and so you can make your sling suture, surgical, anatomic, lingual papilla, below the contact point, again, surgical, anatomic, lingual papilla. You turn your needle, go back to the starting point, and close it. In such a way, you start with the corneal advancement and the stabilization of the keratinized tissue on the convexity of the clinical crown in that portion of the flap which was envelope type. Now you have to improve the quality between surgical anatomic papilla, between 3 and 4, and since you have to place another suture, you go back to the first papilla, which was suture when still you have some tension of the flap, and go more apical with respect to where the first suture was made, and in such a way you improve the stabilization along the mesial trapezoidal surgical papilla, comes back and close. Putting the tip in the middle, and once everything is ready, you close it. At the end, you see that the whole area is completely covered with lining mucosa, and there is no sign of graft exposure, despite we started with the complete absence of keratinized tissue on 2 teeth, that was the canine and the premolar. And if you look at the outcome, you don't see any difference in color, texture, and surface characteristics between the area which was treated with or without the connective tissue graft. This means that this lining mucosa survived above the graft, allows the long time realignment of the mucogingival line, and allows a stability and gives stability to this flap, this that was not stable by itself because made of alveolar mucosa only. Then you can also finalize the closure with a very small needle, 7-0 suture along the vertical easy incision and the adjacent teeth in order to achieve really primary intention wound healing and no way for the blood to get out with respect to the soft tissue margin, and so give maximum stability you can give to our flap. You should always avoid to place your needle inside the sulcus, but remember that the area of the central incisors and lateral incisors should be treated in a separate surgery. Once this area is already healed, let's say at least 3 months after the first surgery. It's very important to close perfectly the vertical easy incision also in the area of the alveolar mucosa, not to create problems of bleeding during the post-operative phase that the patient is always very worried. You see how now verticality was achieved back thanks to the presence of the connective tissue graft below, thanks to the complete absence of muscles in this lining mucosa, which was absolutely lining mucosa of the lip. If you now consider this picture, how verticality was achieved with the lining mucosa with respect to the first picture of your movie, in which you saw that the lip was completely horizontal, it seems really incredible that the same tissue were used. You see it? This was the starting point. The lip was completely horizontal, and there was no way to think at that time that it was possible to give this lining mucosa such a vertical shape to cover completely deep gingival recession and also connective tissue graft with such replacement of the verticality of the vestibulum depth. This is why I insisted so much yesterday to make you understand that in order to make your flap corneally advanced, you don't have to make periosteal incision. In this case, I did not make any periosteal incision, but is the what you have to do is to make your lining mucosa completely free from muscle. So you have to make the superficial incision in order to give back alveolar mucosa the verticality and so the healing. And if you go back to the palate, let's say half an hour after the surgery, you see this is always the situation you have. It's just a bit red in order to demonstrate you that the bleeding from this wound area is really, really, really minimum.